Good evening, friends. For the last many months, we have had a we have been enjoying wonderfully exciting academic sessions on various topics on the behalf of Raigad IIT. Continuing on the same path, today also we have two very esteemed speakers. On behalf of Raigad IIT branch, myself, Dr. Ajay Kohli, and Dr. Vikas Gandal, we invite you all for today's academic session. We begin the session by the President's address. For that, I would like to invite Dr. Pramod Wankhede, sir, President of Raigad IIT branch. Sir.
Thank you, Ajay. Thank you very much. First of all, I welcome all our experts, Dr. Bhushan Chavhan sir and Dr. Nimbalkar sir. And I also welcome all the dignitaries on the board. Dr. Sachin, I am seeing here, Dr. Neha, Mohite sir have joined Dr. Jay Bhandarkar. So, all the dignitaries of the board, on the board, and all my dear friends. Today's topic is very important but very critical and complicated also. We come across many cases of pediatric cardiology, right from after birth. So we need to know the technique and the way of recognizing it, the way of examining it. So early pickup, and after identifying the cases, we need to stabilize the patient. We need to maintain it, and then we need to transport it safely. So for this, we must have some basic knowledge of pediatric cardiology. And for that, we have taken this session. We have got two stalwarts of pediatric cardiology as our expert. Let us take some inputs from them and update our pediatric cardiology so that our patient will get benefited. So I request all to Dr. Ajay Kohli. Thank you very much. Thank you.
Thank you, sir. As we all know, friends, heart is the most vital organ of the body. It supplies blood to almost every organ system of the body. As a result, diseases affecting the heart have the potential of affecting every other organ, and vice versa. This sometimes creates a puzzling symptoms which are difficult to diagnose and very tricky to treat. To navigate us from these puzzling situations, we have two esteemed speakers, Dr. Bhushan Chavhan sir and Dr. Manglesh Nimbalkar sir. I would now like to request Dr. Vikas Gandal sir to start the session by introducing the first speaker. Dr. Vikas.
Good evening, everybody. As you know, transplant therapies for children continue to evolve and march into great knowledge. The advances in interventional practice have changed the therapies that nowhere are these procedures more important than today. We have renowned senior consultant Dr. Bhushan Chavhan. He is MBBS, DNB Pediatric Fellow of the National Board of Pediatric, and he was awarded Fellowship of PS and Faculty of Cardiology in 2021. About his work experience, he has worked as a junior consultant, Madras Medical Mission, consultant intervention in cardiology, the next MD Medical College, Mumbai, where everywhere, all the places he had individually performed, especially about diagnostic and therapy, actively involved in post-operative pediatric cardiac care. About his career single operation, he has almost 155. He has done almost 155 KC closure, KC closure, 160 period event closure, 61 valvotomy, attenuated valvotomy, 5 was speed after sending, 5 more setting, and successfully complete 100 plus variable device closure during with ADA. Here, number of international paper institutions from America, Texas, and he has been invited faculty at various international forum from Africa to Russia, 2016 about his movement and its humanitarian mission across. He is serving in pediatric cardiology in Nigeria, and he was a teacher in the workshop conducted at the University of Nigeria in July and August 2013. He is actively involved in conducting pediatric for the last 5 years. Major role in developing a comprehensive at present, sir is working as senior consultant in international cardiology at across over to you, sir, for the session. Because starting this session, I will let please put in the chat box. After the end of the session, second speaker talk will continue for you. Over to you, sir.
Thank you, Doctor, very much for that very elaborate discussion of my CV. Thank you very much. I am very happy and I feel honored that today I am belonging to Raigad and speaking on the forum of IIP Raigad. So it is a very proud moment for me. And what I am going to speak today about is cardiac interventions in sick neonates. Am I audible?
Yes, yes.
So let me be very clear at the offside.
सर एक बॅकग्राऊंडला खूप आवाज येतोय.
माझ्या सर
भूषण नाही पुढे तर कोणाला जरी दुसरीकडे आवाज येतोय.
हॅलो विशाल सर.
कुशल,
I think rest of us can, if you switch off our mics, then we'll know.
your phone. Kushal. Where shall I?
Now it's gone.
सर भूषण सरांचाच माईकचा इश्यू आहे.
माझाच येतोय सर.
हो तुमचाच आहे सर.
आता आहे की गेला?
आहे सर. जाऊ दे, कंटिन्यू करा आता. कांट गेट rid of it.
ओके, मी थोडा व्हॉल्यूम कमी करतो म्हणजे येणार नाही तो. आय एम शुअर.
काम करा, लॉग आउट होऊन लॉग इन वापरा.
आता येतो? कमी झाला?
येतोय आवाज. तुम्हाला लॉग आउट होऊन लॉग इन बघा.
हा बस एक मिनिट सर.
लॉग आउट होऊन लॉग इन वापरा.
निंबाळकर सर फर्स्ट प्रेझेंट करतील आणि मग मी सेकंड करू, चालेल का सर?
चालेल.
तसं करूया.
हा, तोपर्यंत माझा सॉर्ट आउट करतो.
येस. अजय.
ओके सर. येस सर.
ब्रीफ इंट्रोडक्शन सरांची दे.
Yes, sir. Okay. So we begin the first session. Our first speaker is Dr. Manglesh Nimbalkar, sir. Sir has done his pediatric and fetal cardiology from KM Hospital, Pune, and fellowship from USA. He presently serves as a consultant of pediatric and fetal cardiologist in HN Reliance Hospital and Koinur Hospital of Mumbai, and Jahangir Hospital and Sai Cardiac Center in Pune. Sir is also director of Children's Heart Care Trust, which is involved in funding of thousands of children with congenital heart disease. Sir has done research in rheumatic heart disease, Kawasaki aortic arteritis, and post-operative congenital heart disease management. Sir also has 5 international publications and awards to his name. I would like to now request Dr. Manglesh Nimbalkar, sir, to begin his session. So you can start chairing.
Okay. Am I audible?
Yes, sir.
Yes, sir. Audible and visible.
Audible, right?
Yes, sir.
Good. And can you see
slides are also visible, sir? Yes, sir.
Okay, good. So thank you so much for the opportunity to speak. And I was really confused what to speak because there is too many things in pediatric cardiology which can't be summed up in one PPT. So I asked many people what should be our what kind of presentation we should give to the practicing pediatrician. And Dr. Vansini, Dr. Adikoli, sir, they have told me the common things what we want is important. So I think I enumerated 5 of them. So, fetal echo report, prognosis, cyanosis in neonate, approach, management, transfer, clinical exam, murmur and congestive cardiac failure, medical management of CSD. I will take a cyanotic emergency and a CCF case, and infective endocarditis prophylaxis in present era. So, case one, fetal echo prognosis. Now, you are sitting in an office and you have been asked, called up by a obstetrician, and she wants to know this prognosis of this disease. I think Dr. Bhushan also agrees with me. There is a really lack of knowledge about fetal cardiology or fetal echocardiography. There are a lot of radiologists. They do fetal echo, but what Dr. Bhushan I do is completely different, and what we follow is segmental approach to the critical heart diseases. So whenever a obstetrician asks you, he wants to know about two, three things: whether I should deliver, where I should deliver, what should be the mode of the delivery, local or should I transfer to tertiary care, can NICU backup is needed, each transfer is immediate, prognosis one time and many times. So, what is fetal echo? Is an extensive evaluation of fetal heart to rule out critical congenital heart diseases like tetralogy of Fallot, tricuspid atresia, pulmonary atresia, transposition of great vessels, and hypoplasia of either right or left lung, left heart. It is not synonymous with malformation scan. It is very, very important statement because lot of practitioners they have their concept that malformation scan is the end of fetal imaging. It is not so. Maternal fetal medicine and some esteemed radiologists, they are very good as imaging is concerned. But as you are aware, the fetal heart is a 3D structure. And we take, even for the evaluation of BSD, Dr. Bhushan and we generally have to work at least for 30 minutes or 1 hour sometimes to evaluate ventricular septal defect. And you can imagine, in the fetal heart, it is again very difficult. So very important is malformation scan is not fetal echo. Early diagnosis of critical congenital heart disease is possible with fair degree of accuracy, 90% as early as 16 to 18 weeks of gestation. Early diagnosis makes parental stress less rather than discover accidentally after giving birth. Early diagnosis helps the pediatrician attending delivery to prepare better for treatment and life-saving service. Early knowledge of pathophysiology of specific congenital heart diseases is very important for pediatrician attending the delivery to deal with critical cases. Now, whenever we have a transport, whenever we are asked about a fetal echo or ANC report which is showing a complex congenital heart disease, generally what we prefer is transport of critical CSD, and mother is the best natural cardiac ambulance. So always better to shift mother than to shift baby with so many tubes and so many IVs. Second question is success rate of many heart diseases. As we are moving to a tertiary and quaternary cardiac care centers, and many of them are there now. So it is very important that the success rate, if you compare between cases operated between 1971 to 1979 and 2000 to 2011, you will see this is univentricular heart. See the mortality initially. How bad was the mortality? And see the success rate today. It is still more than 80%. As compared to other things like truncus arteriosus, interrupted aortic arch, transmission of great vessels, total anomalous pulmonary venous drainage, they are approaching more than 95% of the success. So now we will move to a cyanosis in newborn. How do we approach them? What is the management and transfer? Dr. Wankhede sir, is it okay? Should I go to second slide?
Sir, बरोबर आहे, बरोबर आहे.
Yeah,
This is what we want exactly.
Okay. So this is a good picture, and you can see these are the many cyanotic tinge. What we are seeing. Um, Cyanosis in newborn after birth, 3 hours of life is likely to be abnormal, and fetal hemoglobin higher saturation for a given O2. Cyanosis recognition is difficult. So whenever you are in doubt, you have to check with pulse oximeter. Now everybody, because of thanks to corona, we have pulse oximeter at every home. Now, same this case. See, this child had come to the OPD, and parents were and baby also. We couldn't. We thought it is cyanotic, no, not cyanotic. So what we did, we checked with the oxygen saturation. So this is a case with total anomalous pulmonary venous drainage, where there is increased pulmonary blood flow, and therefore the saturation was 92%. Now, is the difficult part. So, is there any screening for the detection of CSD? You have a kid, we have a normal child delivered, and your obstetrician wants that child to be seen, examined by you. Now, your main job is to rule out the serious congenital heart disease. Is it easy or is it difficult? I think it is both. So, what we need to do is check a pulse oximeter at before 24 hours of age or discharge in postnatal ward. Now, pulse oximeter, introduction of pulse oximeter in NICU or in PNC ward has really improved our critical care a lot. There were initially lots of there were no screening, but since the arrival of pulse oximeter, we could detect many cases of PPHN, many cases of congenital heart disease which could have been missed. If you look at a black baby and you may not notice the cyanotic stage, and that is very important. So what we should do is you take a saturation in either limb and you check the saturation. If it is more than 95% and less than 2% difference between upper and lower limb, you see clinically you see follow up, and then if it is normal, then you send that patient home. If it is abnormal, if it is less than 95 saturation, 95% saturation is very important. That's the borderline between the normal and abnormal. But things can go anywhere. This is just an algorithm for detection of CSD. So this is a UK algorithm, and they said that if there is less than 95% in either limb or more than 2% difference, you please send them for 2 weeks. There is another algorithm. There is a US algorithm, and again measurement. They take many measurements. They have measurement one pulse oximeter on the right hand and one put after 24 hours of age. Baby is passed if pulse oximeter is more than 95% and difference of 3% or less between two actions. Again, they measure it after some time, after measurement 1 hour after, and 1 hour after. So, is it enough? Is it only the pulse oximeter screening is enough? No. The pulse oximeter screening, the overall sensitivity for the detection of the CSD is 76%. Specificity is 99%. Why it is so? Because there are many heart diseases, they can have a normal saturation with PDA with the presence of PDA, normal physiological presence of PDA within day 7 of life. So, addition of pulse oximeter to clinical examination significantly improved sensitivity for many CSDs. You have to have a clinical examination. There is no excuse for clinical examination. Now, how do we approach? Now, I was really, after talking to Dr. Wankhede sir, I really thought what should be the approach? Is it how either we should classify or what we should do? So this is a flowchart which the past textbook has mentioned. There is a two broad headings. There is acyanotic or cyanotic. In acyanotic, there will be ASD, VSD, PDA, atrioventricular canal defect. They will come with an increased pulmonary blood flow, and in acyanotic there will be obstructive lesions like coarctation of aorta or aortic stenosis. In a cyanotic, there will be decreased pulmonary blood flow in the case of heterology of fallow and tricuspid. Or there is an increase or mixed blood flow like transfusion of great arteries, PAPVCs, truncus arteriosus, or hypoplastic left heart syndrome. I think I think for us practically, what is important is not this. I think what is important is whether baby is cyanotic or baby is acyanotic. After that, what is important is whether baby is stable or unstable. If baby is stable, you can keep the baby, you can monitor the baby. But if you think baby's color is not good, baby is having respiratory distress, baby is in tachycardia, bradycardia, then you should know this is a critical heart disease and time is against these patients. The neonatal heart is very immature, it can't handle the much stress, so we need to fast track their transfer. Third question you need to ask is whether the cardiomegaly is present. Now, some of the lesions you can diagnose like a egg-shaped heart, you can diagnose a TGA, and if there is a TAPVC, figure of eight appearance, practically it doesn't help much. Practically, in a baby to get an X-ray is very difficult, and even though you get an X-ray, X-ray doesn't help in classifying this. It helps in knowing whether this PhD is stable or unstable. CCF, if the baby is in active CCF, if there is a cardiomegaly, if there is a tachycardia, if there is a hepatomegaly, this baby might be having a TAPVC, total annulus pulmonary venous drainage, where the pulmonary veins are connected to the right side, or transfusion of greater vessels with ventricular septal defects, or it could be only a plain cyanosis with heterogenic fallowed pulmonary atresia or tricuspid. If patient is coming to you in a very shock where you can't feel the pulses and you have a absent femoral pulses, you are suspecting coarctation of hypoplastic left heart or aortic stenosis. So this is what we made for the because in last Maha IIP they wanted to have some degree of algorithm for a person who is sitting at periphery and who doesn't have any access. So whenever we have this, we generally, in addition to your ABC, airway breathing circulation, we have uh, we have proposed this, and if Dr. Bhushan agrees, it will be very good for us. So anticipation and antenatal transfer. Lot of pediatricians, whenever they attend a delivery, they should go through the ANC report. Now the availability of a very good radiology machines uh, and overall improved diagnosis of this heart disease, makes, they make a point and they write it. For example, they find some small echogenic focus, or if they don't know that they write something. We have to screen those antenatal records. Antenatal transfer, if you think there is a diagnosis of left heart syndrome, or there is a there is a serious diagnosis of PAPVC, transfusion of blood vessels, so you should transfer them antenatally. Now, the next thing is breathing, airway, respiration, circulation, four limb saturation, very important. Uh, Post-ductal, pre-ductal saturation is important. Then your clinical exam. See for the clinical examination. Your short clinical. I think many of these pediatricians here, pediatrician who 100 patients in a day. How? What do you mean by short clinical examination? You can finish it quickly, uh, minute, quick process. It is important. Now, this is uh, this is important. Have a prostaglandin in your if you have an ICU. Everyone should have this prostaglandin. It is a one if you have it, because transfer becomes very child PGE. Early echo reference to pediatric cardiology. Now I have put echo later because we are thinking of a pediatrician sitting who time communicate to either Dr. Bhushan or Dr. Me. But since they go, it will be good. And to tertiary care center and transfer. Now what is safe transport? Important is real communication, complete written communication between hospitals. Time it is seen that there is a patient. Even I was transferring a one patient to a patient of surgery. The referring unit ready to get thing in this thing because the relative wanted to and this should not these eco clashes should matter when written communication is very important at this situation because patient comes into the state. We know how it takes how it is to even stabilize a critical neonate. Second is reliable vascular access. Second incident if uh, it is inotropes, low or if you are not filling pulses, it is better to send them on inotropes. Patient air, double check with the airway. A lot of times the patient comes with a blocked TT tube, blocked IV. Same thing. We have lost these children in fraction of seconds. Correct temperature, blood pressure, acidosis, maintain euglycemia. Very important. Avoid 100% of exposure for some cyanotic. Remote meters including heart rate, BP, distal perfusion should be reactive. Is it okay? Should I go to Manoj? Hello.
Yes, sir.
So this is again a office emergency kind of thing. Whenever you are a first year old person following religiously with now have been detected murmur by another pediatrician when it's not around. So it's kind of emergency. I think 8-10 times recently because senior pediatricians think no why we have at that time it was not having. How can you say it is having a heart disease now? And they suspect. So similarly, this of pediatrician who got bombarded with a lot of questions, the family with innocent murmur. There are seven very
सर
sensitive
तुमचा
to
डिस्टर्ब होऊन राहिला आवाज. एक्सक्यूज मी सर. हॅलो निंबाळकर सर,
sir.
तुमचा आवाज मध्ये मध्ये ब्रेक होतो सर.
येतोय सर?
हा थोडं जवळ येऊन बोला. माय
ओके सर.
आवाज आवाज खूप हे तुम्ही इयरफोन लावला बरोबर आहे, फक्त ते ऍडजस्ट करा.
नाही सर, विदाउट हेडफोनच प्रॉपर आवाज येतोय, फक्त स्लो येतोय थोडा. हेडफोन लावला तर डिस्टर्ब होतोय आवाज. अच्छा ठीक आहे. आता प्रॉपर येतोय. Short duration, single, small, limited to small area, non-radiating, soft, sweet, no harsh sounding. You remember the PDA murmur? It will be a very harsh or VSD murmur, very harsh. Systolic, occurring during and limited to systole. Now, whenever you are thinking of innocent murmur, very important is this is what signs are suspicious of PSD. First of all, dysmorphic features. There is feeding difficulties, history of feeding difficulties, suppressive cycles, abnormal vital signs like tachycardia, bradycardia, tachypnea, respiratory distress, raised JVP, abnormal growth, height and weight plotted on a growth chart will be less. Coag, there will be difficult to palpate the femoral vessels. Adventitial breath sounds, wheezing, rales, bronchi, and pleural blood. Chest counter, this is very important. In case of ASD, this will be the only one sign. There will be chest deformity of the patient. Systemic finding, cardiovascular finding, there will be poor capillary field in a case of critical CHD. Displaced point of maximal impulse, edema, precordial bulge, S3 and S4 gallop with a structural heart disease. Abnormal S2, wide and fixed split S2 in case of ASD, and loud S2 in case of pulmonary hypertension. There will be ejection click if there is a semivalvular stenosis. Weak or absent femoral pulses points towards coarctation road. There are gastrointestinal symptoms, ascites, congestive cardiac failure, hepatomegaly, ascites in case of congestive cardiac failure, hepatomegaly, and location of liver. If you see a right-sided liver, you will be there on the right side. But if you are not palpating, you are not getting liver this side, you should palpate on the left side also. So that will suggest inversus abdominal side. Now, what are the clinical recommendations? Structural heart disease is more likely when the murmur is holosystolic, pansystolic, diastolic, grade 3 or higher, or associated with a click, when it increases in intensity with standing, or when it has a harsh quality. Chest radiograph and ECG rarely assist in diagnosis of heart murmur in children. This is very, very important. Lot of pediatricians. So a lot of people, a lot of doctors, they do X-ray and they find that X-ray there is no cardiomegaly, and why should he should have a heart disease? But you remember, if there is a moderate size, even large size atrial septal defect, the cardiomegaly won't be apparent. Family physician should order echocardiography or consider referral to pediatric cardiologist for an newborn with a heart murmur. Even the child is asymptomatic because higher prevalence of the structural heart disease in this population. This is a clinical recommendation by pediatrics. Then why you want to refer these patients? Very important. You want to refer a case of congenital heart disease with left to right shunt like atrial septal defect before they go in ICM migration. Now the ICM migration, whatever we are seeing, is early. Why many of patients when they come to us in first decade with a VSD with ICM migration, with a clubbing, and with this kind of X-ray without cardiomegaly and loss of peripheral pruning, it means you are dealing with a very disease with a isomegaloid syndrome with a bad effect. Again, tetralogy fallout coming diagnosed after 2 years of age, where they have abscess and they have bad neurological thing is should not happen. Again, recurrent respiratory infections in a case of large VSD or heart disease like atrioventricular septal defect, failure, and the vicious cycle of convolution. To break all of this, to prevent all of these complications, we need to refer them early. Now, fourth, I'll come to medical management of CSD. Cyanosis and shock. When a patient is presented to you with cyanosis with a saturation of less than 30-40, and patient is in shock. Now, what is your important drug is alprostadil, prostaglandin, E1. We'll talk about CPF myocarditis, digoxin, lasix, and was typical masala, what we generally use for to treat this CF in this patient. So, more about prostaglandin. This will be 1 ml prostaglandin alprostadil injection having 500 mcg per ml. Now, this is very important in the temporary management of suspected ductus arteriosus in congenital heart disease, cyanotic, and shock and emergency. Whenever you are thinking of a very critical CSD cyanosis, this hyperoxia test usually used to do it, and there are many fallacies about this, so it is not needed. Very important is you should have adequate ventilation because apnea is a side effect. What we should do is you at least get an X-ray chest, because rarely we have found that patient is having some emphysema or some pneumothorax, and we are giving posting. You should maintain the serum glucose, you should maintain a normal ABG, and you should maintain a normal GCV laser. Normally, there are many methods to use prostaglandin. Generally, if you want to not overload the patients, so it is very important to put one vial and use the complete vial, which is of 5,000 rupees. You put one vial in 50 ml of D5 or D10 dextrose and make it as a 10 mcg per ml solution. A starting dose of 0.05 mcg per kg per minute can be achieved by starting 0.3 ml per kg per hour infusion. So this won't overload the patient, and this is really sufficient to add. All mix. It is only stable for 24 hours. After 24 hours, you have to discard. Now, what are the adverse reactions? 25% cases apnea, fever, and flushing is there. Contraindication, there in obstructive TAVC, there is if there is a mitral atresia, if there is a transmission of great arteries, restrictive PFO, it will complicate the situation. So once you start it and once you don't get a favorable response, you should not continue. So this is a Cloharty adopted recently from Jill Varnosky, and what we generally follow is not making a total 50 ml, total 100 ml. We make it a 1 vial in 50 ml. So this is how we should use it. Coming to another drug, digoxin. Digoxin, initially enthusiastically uses of digoxin has really reduced. We generally use it for the patients who are having, they are presenting with a congestive cardiac failure or repeated admissions. We generally give it. We give it in a very small dose, not 10 mcg per kg per dose. We generally give it a 5 mcg per kg per dose in 2 divided doses. There are many people who are against digoxin, and they're right. But what we generally observe, this digoxin, NVAS, and LASIS combination always works for this control of CCA patients. Precautions, a specific point holding information for parents. We have had children where they have admitted with a digoxin toxicity because they have taken a digoxyl bottle, whole bottle they have taken, and we have to admit these patients. Second point is it will cause some bradycardia if there is a toxicity. So you should monitor the heart rate for these patients. Another wonder drug is Lasix. One of the least toxic diuretics in pediatric, but in neonates because of sensory hearing loss after long administration, it is really they don't use it so often. But in a Cochrane systemic review, the broad consensus is diuretics appear to reduce the risk of death and deterioration of cardiac failure and improve the capacity in a dose of 1 to 2 milligrams per kg per day. Now, third drug is naloxone. SC inhibitors in pediatric CSD, pediatric patients with heart failure. Again, as I said, SC inhibitors like enalapril is freely available, like digoxin and Lasix, and they are very good drugs to start with. Their first pass effect may be more in infants. So BP monitoring is very important when you want to assess the hypertension. Be careful in neonates, especially less than 4 months, because the renal toxicity is there in these groups. Hypotension, renal failure usually occurs within 1 week. So it is important to scan the kidney for abnormal kidney diseases or to document the normal renal kidney functions. Starting dose can be 0.1 to 0.5 mg per kg per day. So, stepwise introduction of medical therapy in heart failure. Whenever we have a child like this, we generally start with a pulse diuretic, NVAS, and then we add digoxin, then we add beta blocker. Aldosterone antagonist, a lot of people they add, but I don't add so often because its utility is not guaranteed. You have been asked to a patient is undergoing a surgical some sort of minor surgery, some sort of dental procedures, and he's operated recently with a ASD patch closure or device closure. Now, what should we give for these patients? Now, target group for prophylaxis. This is a 2007 guidelines, and they are important because if there is prosthetic heart valves, prosthetic materials, previous infective endocarditis, unrepaired CSD, there is an increase in this is the group where high risk of developing infective endocarditis with these procedures, and they should be given a infective endocarditis prophylaxis. A lot of people, they ask what is the infective endocarditis. We should start them like rheumatic prophylaxis. No, you should give only one dose, 30 minutes, 60 minutes. It has recommended amoxicillin, clindamycin is out, ampicillin, cefazolin, ceftriaxone. These are the simple flow chart they have mentioned, and we generally follow this. Thank you.
Thank you, Dr. Manglesh sir. Actually, I had prepared 4 questions regarding this session, but you have already answered all the 4. I would now like to request Dr. Bhushan Chavhan sir to begin his session.
The layout of the topic, how to identify sick neonates with cardiac problem, is what I'm going to stress more. And the last few slides only on interventions, because I think that is interventions are basically the only high skill thing for the cardiologist. So I said I'm going to discuss more on identification of sick neonates with cardiac problem, and only last few slides on interventions will be there. So these are the common scenarios, very common in our NICUs. Term baby born, early morning 3 a.m., emergency LSCS, meconium stain, liquor, with respiratory distress, with desaturation, with grade 3/6 murmur, saturating around 92%, versus a 36 weeks late preterm baby, day 4 of life. This baby was also born through LSCS, initially comfortable, but develops respiratory distress on day 4 with grade 2/6 of systolic murmur. That baby is also saturating 92%. Now, how many of you say that which one of this is critical congenital heart? Is what I'm going to make you understand.
Second one.
In
Second
my
one.
talk.
Second one.
So I'm happy that everybody,
Second one.
most of you have opted for the second one. But the reasoning behind that is what I'm going to explain. Why second one is the correct answer, but why do I say that, and how do we approach these kind of cases? So we all know that the incidence is around 8 to 12 per 1,000 life. Interestingly, even after 3 to 4 decades of so much of interventions and so much of research going on, the incidence is prevalence is still the same. And 1/5 of this is because of the critical congenital heart, which requires intervention early. And if this normal screening diagnosis treatment is available, 90% patients born with heart disease will survive to adult life with good outcome. Now, what are the misconceptions that we all know that it's a rare? It is not. Even if diagnosed, not much can be done. It is wrong. Most congenital heart cannot be corrected in early infancy neonatal period. It is absolutely incorrect statement. And after treatment, not many would lead normal lives. All these are myths. How do you differentiate a critical versus non-critical heart? And what you understand by critical? Example, severe coagulation, hypoplastic left heart, BGA becomes a critical lesion, and a tiny muscular VSD, bicuspid aortic valve, mild PS, they become a non-critical one. When I say critical congenital heart, I mean serious malformations that remain an important cause of neonatal mortality and morbidity. And we classify them into 3 simple categories: cyanosis, shock, and respiratory distress. So if you can just keep this one slide in your mind, most of our problems will be solved. If it is cyanosis, that means it has to be decreased pulmonary blood flow, either tetralogy or tetralogy variant, or TG. If it is shock, it has to be either obstruction to the outflow of the heart or the inflow of the heart, either tricuspid atresia or critical aortic stenosis. Shock can also be because of the pumping part of the heart or cardiomyopathy. And tachypnea, when I say, it may be a feature of congestive cardiac failure in a newborn that may be secondary to a large PDA or a significant bidirectional shunt. So these are the 3 broad classes that we are going to discuss in this next couple of slides. I take them one by one. So when I say cyanosis or shock, what I'm trying to say is duct-dependent systemic circulation will present as shock when the circulation to the peripheries is not made. So there is a significant obstruction like hypoplastic left heart, critical aortic stenosis, Schoen complex, transposition with PDA closing down, they become duct-dependent systemic. And when I say duct-dependent pulmonary circulation is where the PDA is the only source of blood supply to the lungs, and that becomes tetralogy, pulmonary atresia, intact septum atresia, critical PS, tricuspid atresia, pulmonary atresia. So there is no antegrade flow across the pulmonary valve. So that becomes a duct-dependent pulmonary circulation. Now, just consider a case that we have a baby which is born, and when should we suspect a newborn with a heart disease? So as I've told you, with a cyanosis or with a heart murmur, which sir has already discussed in his talk, but I will just touch a little more on that. When a newborn presents with hypotension, poor perfusion, metabolic acidosis, and with features of heart failure. Now, cyanosis. What do we know about cyanosis? That it is not very apparent or not that common in a newborn that can be easily picked up, but it indicates that the presence of right to left shunt. Absence of history of cyanosis does not rule out cyanotic heart disease. A very important statement. Tetralogies are sometimes born as pink babies, but as they grow, then we realize only while crying you will see cyanosis, or activity you may see cyanosis. History of spells and spotting in older children will be detection of cyanosis. Pulse oximeter, we know, we have been checking this for after the corona episode. But what is the normal value? The cutoff is less than 94% after 48 hours of birth. And that's a very important tool. And when you see visible cyanosis, when the saturation is less than 85%. Now, there are some myths and statements that one should remember. This is as per the American Heart Association statement. We all check right upper limb and the right lower limb. But the most recent documents, they say that it is the right ear lobe is the safest place to get a preductal saturation, as the right arm may not be preductal in presence of an aberrant right subclavian artery. So what is that? So this is the normal aortic branching pattern, brachiocephalic, common carotid, and the subclavian. They are the three branches, and your usually subclavian comes as the first branch. But when there is coarctation, the right subclavian can be an aberrant branch which comes after the PDA, so that becomes a postductal. And in this case, even your right upper limb will show you a postductal saturation. So it is ideally you have to take a right ear lobe and a right lower limb. And the ear lobe pulse oximeter parameters are little different. The way you attach it, it's a button like a oximeter probe. Now, what is differential saturation? When the upper limb, lower limb saturation difference is more than 3%, we call it as a differential saturation. And the commonest conditions are transposition, coarctation, PDA combination. Now, differential saturation with lower saturation in the lower extremities. This is the most common. Most common in the sense the upper limb is normal, but the lower limb is blue. Very commonly seen in newborns if the PDA is open and the pulmonary artery pressures are high. So in pulmonary hypertension, there is an obstructive lesion in the left side of the heart, because of which there is all back pressure and the lungs are fired. So the PDA becomes a rescue pressure measure for these children. So there will be, in case of coarctation, critical left-sided obstructive lesions and infradiaphragmatic TAPVC. Next, could be possibilities. We have seen newborns where there is a cyanosis, normal cardiac auscultation, but you don't find anything in the heart. I still remember a case which I've seen one of the NICUs. They called me 3 times for echo. Are saturation vadatas nahi hai. You are saying the heart is normal, the X-ray is normal. What is wrong with the baby? In babies, you don't see clubbing because they are newly born. So then you come the possibility, if they are older children, if clubbing is absent, it could be myth hemoglobin. If clubbing is present, it could be anomalous systemic venous drainage. The IVC may be connected to the left atrium, which is extremely rare, but it could be a possibility. Or the right side of the heart is very small, called as hypoplastic RV. So this slide is very important, I think very crucial in our day-to-day practice. Then cyanosis in newborn. When you know that there is a cyanosis, we want to know whether it is respiratory or cardiac. So supply 100% oxygen for 10 minutes. If the saturation picks up, giving oxygen, it is almost, most of the time it is confirmatory that probably I'm not dealing with a cardiac cyanosis. To confirm that, we take an ABG, and if it is the PO2 more than 300, it becomes crystal clear that it is respiratory cyanosis. If the PO2 is less than 150, it is cardiac cyanosis. Most common, because of these babies are tachypneic, you will always have a low PCO2. X-rays and ECGs, I know X-ray is very easy to pick up. If it is oligemic lung fields, if the cardiac shadow is normal, is what you need to see. ECG is sometimes difficult, even to get an ECG in a newborn, and to interpret becomes a little tedious task. Now, this is what I have just to summarize. In cyanosis, clues to cardiac causes: absence of grunting, severe intercostal retraction is absent. Differential cyanosis, which I spoke, reverse differential cyanosis, where the upper limbs are pink, the upper limbs are blue and the lower limbs are pink. That happens in a TGA, coarctation, and PDA. An abnormal physical examination, ECG, X-ray, and abnormal hyperoxia test. Now let's come to the second variety of shock. That baby could be just lethargic, mottled, cool extremities. It seems like varying degree of metabolic acidosis, which is not getting corrected. Think of not just sepsis, but it could be a duct-dependent systemic circulation. Think of heart disease as a cause of shock, and remember that we have to proceed with resuscitation simultaneously with the diagnostic workup, because these babies, they do not give you time at all. So what are the clues there? You check all four limbs pulse, especially the brachial and the femoral, and blood pressure in all the four limbs. Cardiac examination is the clue here. I know that since pediatrician, we have excellent pickup in getting hold of the murmurs. So any soft systolic murmurs, you should a little more training on identifying a single second heart sound is what gives you the clue. X-ray, pulmonary vascularity, cardiomegaly. ECG, again, very important here. I have some tricks which I'll tell you later how to identify these things. Now, second heart sound, only some two important points that I want to make. Usually the second heart sound split occurs by around after 48 hours of life. So if you hear a split, what does it tell me? That there are two important messages. Conditions with elevated pulmonary vascular resistance are unlikely, and conditions with reduced pulmonary blood flow are unlikely. So if your S2 is split, decreased pulmonary artery blood flow, and PPHN is less likely for this child. Again, if that split can be made out, what are the problems that we have ruled out? This is a very important slide. If you are able to appreciate a split without echo, I can put my finger saying that this hypoplastic left heart probably is not there, arch interruption less likely, transposition less likely, pulmonary atresia less likely, and obstructed TAPVC less likely. Now, examination of the murmurs. Systolic murmurs are easily picked up. Diastolic murmurs needs a little more training, which is difficult sometimes. Continuous murmur, we rarely hear it in a newborn because the diastolic component is masked by the PA pressures. A very simple slide again to tell you, if within the first few hours, if you hear a murmur, it could be a closing ductus, or for an asphyxiated newborn, it could be a transient TR murmur, which is easily heard. Or it could be for a preterm, early or a late preterm, excessive flow across the small pulmonary arteries produces a turbulence. So that is called as a physiological PS. Again, a very important slide. We rarely do complete examination of a newborn, but we do feel the precordium of a newborn. And if you feel the thrill in a newborn, it becomes a confirmed diagnosis of tricuspid atresia, because it is the only diagnosis where you feel a thrill, as the VST in tricuspid atresia looks anterior and the jet will hit the precordium. It's towards anterior of the part of the chest and you can feel the thrill. So I repeat, if you feel the thrill in a newborn, it is 99% of the times that it could be tricuspid atresia with a VST. Now look at this X-ray, a very common X-ray. It looks as if ground glass appearance. So differential diagnosis of an obstructed TAPVC should always be kept in mind looking at this kind of X-rays. A very important slide again. When I say we all are expert in picking up cardiomegalies, but pulmonary venous hypertension, there are certain subtle features that one should be looking out for. And this one slide will tell you all those features. Pulmonary edema, which can be seen Curly's line, sometimes fissural effusions. See the redistribution of the blood more in the apical areas, and pleural effusions could be a possibility. So all these features have to be looked out very carefully. And before echo, if you're able to make out these features, that tells me that probably there is an LV dysfunction in an asphyxiated baby causing pulmonary venous hypertension. So that you have to treat it accordingly, considering classics. Now, a difficult task, ECG, but I thought I will show you only 2 or 3 ECGs. What you need to look in this ECG from a neonate point of view is only one lead. Now remember this trick. When I say normal, sinus rhythm, most of us are able to pick up because P wave following QRS is a normal sinus rhythm, normal sinus tachycardia. I'm interested to know from the ECG only the axis in a newborn. How do I make axis in a newborn? For that, I should know what is normal. For normal, in a newborn, it is always a right axis. So the trick here is looking at AVF. AVF is always positive. So the mnemonic I remember is put your best foot forward. Your foot has to be positive. When your foot is positive, it is right axis. So AVF, F stands for foot. If it is positive, it is right axis, it is normal. And look at this now. If your foot is negative, there is something wrong. That means it is left axis, and any left axis in a newborn should always be investigated. So this is a marker of a congenital heart. It just, you should not take it very easily. Echo, you all know that echo is a gold standard. We differentiate innocent murmur from pathological murmur, which Dr. Nimbalkar sir has already explained in his talk. But sometimes it is wiser to use your cardiologist in the right way. When I say what is urgent, what is early, and what is elective is what I'm going to next 3 slides. Early, likely significant heart disease, it's an urgent echo, you need to come. What are those conditions? If the saturation is less than 94, if there is pre-ductal, post-ductal difference more than 3% persisting, weak femorals, and signs of heart failure or shock, you should have an urgent echo for that. And we have heard Dr. Kulkarni madam also telling you about the targeted echo. Only 1 or 2 use sometimes, even by the neonatologist or the pediatrician, makes a big difference. The second category, early echo. It is not urgent, but we know that this baby has got some heart problem which needs evaluation, but the baby is not sick. What are those conditions? It could be dysmorphism, abnormal heart sounds, abnormal murmur, which has a little higher intensity. It could be a systolic murmur, diastolic murmur, or abnormal location of the murmur. So these echoes should be done before discharge. And the third category, wherein there is a less likely possibility of a heart disease, but an echo must be done. So around maybe 2 to 6 weeks where well infant, no signs of heart failure, normal pulses, normal saturation, only a soft systolic murmur. An infant or neonate which is thriving well, and we just hear a soft systolic murmur, probably a physiological murmur. So those echoes should be done around 2 to 4 weeks. Now, having said all this, so that gives you an identification of the problem. Now, how do you treat the problem? The commonest miracle drug is prostaglandin. Even if you think of an heart disease and you are sure that probably this baby has a critical heart, start prostaglandin without thinking much. The interventions for these patients could be based on the echo diagnosis, maybe in the form of palliative interventions like PDA stenting, RVOP stenting, or valvotomies perforations, or surgical could be BT shunts. Prostaglandin, we have already heard a lot from Dr. Nimbalkar sir. It is an L-prostadil, is the common name, 500 microgram per 1 ml. How do you make it? Dissolve 1 ml in 50 ml of 5% dextrose. It's well compatible only with dextrose. Start at a very minimal dose of 0.025, that is 25 nanograms, and then gradually increases to 50. The maintenance dose should be 50. When you start at 10 to 20, there is extremely rare chance of apnea. We do not need to intubate these babies. This is for the last 3-4 years. I have rarely seen any baby on prostin having apnea with this dose, and we have safely, the best example I can give you is we have been receiving babies from Mauritius. None of those babies were intubated. They were just put on prostin minimal dose and transferred. So maintain this dose, usually less than 0.05 mics per kg per minute, and things will be very clear. Now coming to the intervention part of it, the first slide, you see there is a catheter in the aorta and there is a wire, and over the wire there is a stent which is inflating. This is called as PDA stenting. We do this kind of a procedure when there is a duct dependent pulmonary circulation. We rarely do this procedure for a TGA. It is very commonly done for tetralogy, atresia, intact septum atresia, because you want to keep the PDA open. till the baby undergoes a corrective surgery. The second slide here is called as RVOT stenting, where you see a stent in the position of the right ventricular outflow tract. This is done for neonatal poor branching pattern tetralogies, extremely hypoplastic pulmonary arteries. We want to increase the flow to the pulmonary arteries, and this is the native way in which we can do that. So we do this kind of procedures in the cath lab. It is again through a catheter which points into the RV, and through that we cross the pulmonary valve, you do the balloon valvotomy and put a stent there. This is how an echo looks like. You see those shimmering shadows there. That is the stent which is across the RVOT, and there is an increased flow. This was done for a 2.5 kg baby with tetralogy with hypoplastic pulmonary arteries, where the saturations were around 60s, and after putting the stent, it became as good as 90s. So it is just like it turns the pink, blue babies pink. This one, which I had already showed on the Sunday CME, where perforations of the valves are done in critical PS, critical AS, balloon dilations, very essential to keep the cardiac output open and salvage the child. So these become more like not just palliative, complete correction for children. Now again, the scenarios which I showed you in the starting, as you all rightly mentioned, obstructed CAPVC, because it was a duct dependent. The day of closure of a PDA is usually day 3, day 4, and any baby who develops symptoms on day 3, day 4 should be critically looked at from a congenital point of view. Thank you very much. I hope I have touched whatever expected from my side.
If anyone has any, I mean, audible?
Yes,
Hello?
very well, very well.
Now it's okay. Yes, now it's clear, Vikas.
Yes, sir, आवाज? Hello?
Oh, ekdam
Yes. Barabar.
Thank you, Bhushan sir. It was a very nice, elaborate lecture, and everything was explained very simplified way. I think most of the we have been everyone has understood about the simplified way of understanding the cardiac importance of detecting the southern seas, and how do we detect the cardiac patients, and when to intervene and when to refer, when to early refer the patients to the cardiologist.
Yes, please.
Hello.
Very informative, very crispy. Both the lecturers were up to the mark, but exactly what we want, that you give. Thank you very much. So now the forum is open for question and answer.
Sir, I have one question regarding the TET spell which we see in TOF patients. Am I audible, sir?
Yes.
Yeah. The TET spell, sometimes the patient presents in the known case of TOF. We know that we put them in that niches position and we give them oxygen. Apart from that, means what can be done in the OPD, and how long should we do it? When should we not just wait and we should immediately rush to the tertiary center, or when can we wait to the scenarios? If you could like throw some light.
So to answer your question, make it very simple, sir. TET spells usually occur in tetralogies with good saturation. So that means their nervous systems are not acclimatized to that reduced oxygen saturation. And any early morning, any stress, excessive crying puts this child into a TET spell. So the most important thing that the first thing that one should do is supplementation of oxygen and knee chest position, as you have rightly mentioned, as it displaces the mesenteric oxygenated blood and tries to reach the systemic circulation. Thereafter, you have to calm the child. Ketamine is not easily available in most of the OPDs. So next important step should be putting an IV line and giving it a good boluses of normal saline followed by soda bicarb. That could sedate the child. Never ever consider adrenaline or any other inotropes for these children. Usually they will occur in children with maybe uncontrolled or some form of beta blockers which is continued. The drug of choice for TET spells are ketamine, fentanyl, beta blockers like esmolol, metoprolol, but none of these are easily available in your OPDs. So only fluids, soda bicarb, calming the child, soothing the child is what you can do. never ever observe any cyanotic babies in your OPDs. I think these kind of children should try to reach the tertiary centers as soon as possible.
Sir, what is the alternative for ketamine then?
From our side, sir, phenylephrine is the drug of choice. If ketamine not available, phenylephrine may be available in your OPDs or pharmacies. Start by 2 to 5 mics per kg per minute as an infusion. That causes rise in the systemic vascular resistance and prevents the child from going into further spell. Something to calm or sedate the child is also very important. Some role people have used propofol and midas, but it does not have that very key or active role to be played. Anything else Nimbalkar sir would like to add?
Sir, like Dr. Bhushan has pointed out, this patient generally have a good saturation. They come to you because of precipitating factors. Now, whether that is fever, there will be some fluid loss, acute gastroenteritis, they will come to you. Very important is to hydrate them. Very important. To hydrate them is very important. To put an IV line, to give small dose of sedative. Now, midas generally is quite commonly available. So generally, midas in a sedative dose, sir, not in the 0.2 to 0.4, 0.5. 0.1 mg per kg is sufficient for this baby. But more important is hydration. Very important. Each is patient hydration, and as this patient, you cannot now leave them and you cannot keep them also. You are in some scenario, but you should monitor the oxygen saturation by pulse oximeter. If your pulse oximeter saturation is persistently less than 60, sir, then you have to transfer them on oxygen to a tertiary care center. You don't have to wait. Sometimes if they respond, again, same thing. You need to document what is the degree of obstruction to the RVOT by doing this, and to send for RVOT or PDA intervention. So that is very important.
And from my side, sir, most of us are scared that something will go wrong. He will lose. But it's rare that tetralogy, spelling tetralogies, those are usually robust hearts. So they don't give up that easily. And their CNS systems are also very much well adjusted to the problems. It's only that sudden change in the PO2s which trigger the spell. And there have been various theories. What is the exact cause? Nobody knows. Some say that there are receptors in the infundibulum. Some say there are receptor with the respiratory center. But the mostly accepted ones are that probably infundibulum is the one which causes the problem. So we need to do something to relax that infundibulum. And beta blocker is the only choice. Short acting beta blockers like esmolol are the drugs of choice and not propranolol in IV doses.
Thank you very much, sir. Another question which sometimes I get confused is the tachycardia, severe tachycardia. Sometimes high fevers, especially in COVID times, means in adult children, high fevers also give a rise to tachycardia. Sometimes it goes to 160, 170, especially children when they are less than 1.5 to 1 year. And so, how to differentiate whether that tachycardia is just because of the fever, and sometimes, as you know, below 1 year, that fever does not subside with paracetamol, I mean, which is the only drug of choice below 1 year. So it takes time for the fever to come down. So when should we in that even in so when should we think about cardiotoxic cardiac involvement also, or we should what are the other telltale signs where we should not just keep it as fever related just because of the fever and not because of cardiac involvement also.
So to answer your question, if I read your mind very clearly, you are trying to ask us whether the tachycardia is out of proportion to fever, and does that tell you that there is an underlying cardiac problem to this child or not, is what you are trying to ask us.
Yes, sir, exactly.
So most of this time that we have realized that we know that with every 1 degree rise, there is 10 pulses more. Your heart rate increases by 10 beats per minute for every 1 degree rise of temperature. So if I say that for a neonate, the heart rate has been between 150 to 80 or 180, and with a temperature of around 102 or 103, still after reduction of the temperature, all the measures you will try to get the temperatures down. And how is your heart rate variability occurring? If it is a persistent tachycardia, irrespective of the cause, is a worrisome problem to me. And if I have to tell you a figure, anything persisting more than 200 in a neonate is to be considered with a pinch of salt. So that is a sign that probably there is an underlying cardiac problem and which needs to be seen. The second important point here would be, along with the tachycardia, what is the rhythm of the child is need to be seen. So most of your times your monitors will tell you the plethysmographic trace becomes a good indicator whether there is a pulses alternance happening or not. That means with every tachycardia, is there the cardiac output well maintained? For example, myocarditis, the cardiac output may vary with every beat. And that can be easily picked up with a plethysmogram on pulse oximeter trace. Your sudden trace will be high, sudden will be small, alternating, like called as pulses alternate sometimes. So these things should be picked up. These are subtle signs. And baby irritable, excessive crying, out of proportion, sick. These are again a telltale signs. For so along with tachycardia, I would say if the primary problem has been taken care of, and if the tachycardia persists, which is out of proportion, one should definitely look at the cause from a cardiac point of view. Nimbalkar sir, you want to add something more?
Sir, in relating to this only, if we find that supraventricular tachycardia,
Yes.
so how to treat? Because we don't have adenosine or amiodarone. In that case, can we go for Valsalva maneuver or some ice packs in our OPD practice? I'm consider the peripheral centers.
Absolutely, absolutely. Very good method, sir. Very, very important method. But now, whenever you have a child with SVT, you need to this vagal maneuver has to be very sudden accidental hit of this on the face with ice or palpation of this or with a pressure on the carotids, on the both carotids or massage, carotid massage is very good way of thinking. But for neonates, since the neck is small, generally the carotid massage I have found it not very practical. I don't know about Dr. Bhushan's input, but I think the application of ice to the and it's a good way to treat this SVT. And as you said, sir, this adenosine is not freely available. But again, two very important maneuver is to get IV line to calm the baby is important in this way.
So from my side, what we have been practicing is the concept is you have to stimulate the trigeminal nerve. So take ice cold water, dip a cloth of your handkerchief in that ice cold water, and just cover the uh, area near the perioral, near the nose. That stimulates the trigeminal nerve, and most of the times it will abort your SVTs. You will not have to do anything beyond that. But it actually should be like ice cold. The baby should be shivering with that. So once something like touching the trigeminal area, it will stimulate your vagal reflex, and that is going to bring down your heart rate. That is one. Secondly, in older children, sometimes you can ask them to strain, like for when you sit for squatting positions, like for passing stool. That could be a reason. Then for older children, you can also ask them to do a Valsalva, to blow inside a closed bag or something. For smaller babies, I think for SVT, this simple using ice cold water and handkerchief idea around the perioral area works wonderful. So you can try that next time. I'm sure it will be useful. And the other method, the other point also, one should also be having adenosine in once in a while in your clinic should be available because it's a very safe drug. People do get scared of giving adenosine, something will go wrong, but it has a very short, extremely short half-life. Nothing goes wrong with adenosine, even if you give an extra additional dose, it just gets quickly evaporated from the system. I have seen this many times.
Thank you, sir. Thank you very much. Thank you for elaborate answer.
Anybody else has any questions? Moses sir?
Ajay, is there a question in chat box? Please see it. Chat box मध्ये काही questions आहेत का?
नाही sir.
Dr. Ruhi has asked some question. Dose of ketamine in TET spell, dose of ketamine fentanyl in TET spell. So these are given in the regular anesthetic doses, like 1 to 5 milligram per kg. Ketamine is 0.1 milligram per kg is already mentioned here. So the whole idea is to calm the respiratory center. And excessive sedation with these drugs, be very careful that this is to be given only in the tertiary center where your intubation things are ready. That is the very key point.
Important point. Very important point.
It should not be given in OPD basis.
Office practice is not a good.
I have one more question. How many of the pediatricians have a ear lobe pulse oximeter? Everybody has only
Finger probe. Right.
I think it is time that we all should.
Is it costly or is it?
No, it is cheaper, sir. Not too costly. And very easy also, like a button probe.
Like the crocodile.
Yes.
But it is very reliable.
Yes, very much, sir. And you will see that compared to the finger probe, it gives you a very peculiar proper trace.
Sir, can you name the company? Kulkarni madam has asked.
And where available?
And where is available?
Yeah, maybe this I will forward it on the group. As of now, it is there with us at Apollo Hospitals. While I'll find out the company and send it to you.
Sir, my another question is that in OPD, if we find accidentally absent radius, femoral and some higher side of blood pressure, we are detecting coagulation. What is our next step then? What should be our next step?
The next step is to say.
Right, but how to stabilize patient there?
Sir, so you are dealing with the hypertensive emergencies or what blood pressure you are getting?
Yeah.
It is in a very severe range. It is better to transfer them to PICU, sir. It is very important because they don't deal to your normal thing. So it is better to transfer to PICU where we can have a graded decrease in blood pressure, and we can send them for intervention like coax stenting or plastic, where we can do that and we can expect decrease.
So, from my side, sir, if you are to see a patient of coarctation, if it is a neonate, usually there are two presentations. Either the baby will come crashing to you. Most of the time, it will be a neonate or an early infant, because this coarctation has developed over a period of time without developing the collaterals, or the child will be an adolescent who will come to you after 10 years of age, where hypertension will be picked up and there will be plenty of collaterals. So most of the time, the early part, the early infancy neonatal part becomes an emergency where you have to deal with these kind of children as a critical heart and you have to send them an interview. The elderly part, this hypertension most of the time is well tolerated because it is over a period of time, and it is just that accidentally it has been picked up. So you need not treat it starting just an antihypertensive immediately, but it needs a proper workup for these kind of children. And as the sir has rightly mentioned, that we need to have a proper echo, CT, and then consider the primary cause, treat the cause, and keep them on a good dose of antihypertensive agents, and need a proper monitoring over a period of time. Because here we know that even if you have corrected the coarctation, there is something called as aortopathy which happens, and they have this lingering hypertension over a period of time.
Another question that's come in the chat box is, what is the drug of choice for PSVT?
So if I see a case of paroxysmal supraventricular tachycardia, the first thing that I do is whether the child is hemodynamically stable or unstable. If the child is stable, you have to first do adenosine test. Adenosine should be always given in that regular dosage that we always give around 1 vial or around 10 mics per kg per minute, fast and very through the nearest access to the heart, and make sure that you record an ECG during the same. So it has two purposes. If you have bradycardia after giving adenosine in this child, what does it tell you? That your AV node is involved in the process of tachycardia. So it identifies the tract of tachycardia, and second, what is the cause? If that tachycardia has been aborted and it has come back, so that starting of the tachycardia with a P wave or QRS also gives me a clue whether it is an AVRT or AVNRT that I'm going to deal with. And if that tachycardia has been completely aborted, so that means that my adenosine has been good enough in completely knocking down the AV node. So when you know that that AV node is involved in the development of the tachycardia, the next drug of choice should be either digoxin, that could be my second possibility, or calderone. These are the only ways. So the message that I want to give is the role of adenosine is very crucial. How you give it, whether it acts or not, and when it acts, you have to document an ECG at that point of time to know the cause and the effect. Both have to be documented. So it will identify the problem. For example, if blocking the AV node, I get to see the flutter waves. So what is the cause of ESVT? Atrial flutter. So flutter has manifested paroxysmal supraventricular tachycardia, and to treat flutter, I need to start with this. Am I clear?
Yes.
Thank you, sir. Thank you.
So, any other questions? Ajay?
No, sir. That was the last one.
I have
No
one more
question.
question.
Okay.
Don't ask her. Don't ask her.
It's a simple question. Most of our NICUs, we have babies coming with us, and echocardiography is not that commonly available. Babies are sometimes critically asphyxiated sick. What is your drug of choice or inotrope of choice for these kind of babies in this without an echo?
Mohit sir, question to you.
Yeah, I was going to say the same thing.
I'm patiently listening to both the stalwarts. Before I answer your question, tell me how many times you got vagal maneuvers working in your SVT? What's your statistics?
So if it is a very small baby, sir, the trigeminal area is very active. Only that we have never tried it. It should be the first thing that one should try before giving drugs, and it works. Because the vagal tone is very high in babies, we should take an advantage of that. Now, the point that how many we have treated, babies who have come to us are mostly adolescent ones. The infants with PSVTs were very rare, sir. So we have not tried these kind of maneuvers on them.
It sounds more of theoretical rather than practical, though we have tried in few babies and infants, but we rarely got it, honestly.
I agree with sir. I agree with sir.
Those don't waste our time. The longer the arrhythmia stays, more resistance likely to happen. So we may not. Coming to your question, asphyxia with myocardial depression, first line that I use is usually adrenaline only. I usually with 0.05 or 0.1. And then later on, you may have to titrate. Most of these babies, they go on to cooling or something. And then sometimes the hemodynamic further deteriorates and you'll end up getting multiple drugs. So vasopressin is the next one that I quite often prefer nowadays. So adrenaline followed by vasopressin. That's usually a choice if it is hypotensive. And then sometimes they're having PPHN and all. Then Bhushan is the boss. So it's a milrinone that comes in, depending upon the. Obviously, by this time he's on with the invasive blood pressure monitoring. So further things are guided by the blood pressure ranges, the diastolic, the systolic, and of course the APGs. But as you said, the first line usually I prefer is Adri 0.1 mic per kg per minute. And then subsequently you titrate with multiple. Second could be vasopressin. That's how usually we do.
the message that I wanted to convey was like probably maybe after 3 months or 6 months, sir, your vasopressin will be number one and adre will be number two.
But it possible. I'll tell you a very interesting thing. This particular question about, I mean, Tata Hospital conducts a workshop called as thematics. And this is being done traditionally for last almost 15, 20 years. And in the hemodynamic workshop, that's one of the best probably in India. And there we had asked this question. Physiologically, if the body comes in hemodynamic compromise, the first endocrine to be secreted is ADH, antidiuretic hormone. So basically, that's what will retain your blood, I mean, water loss from the kidney, as well as it will compress the venous capacitance vessel. So it's kind of auto bolus. If that is so, then in shock, why don't you use adenosine as the first line? I mean, your ADH as the first line. Obviously, nobody has worked it, but perhaps worth doing a study on that line. Perhaps one of the thinking is in the initial phases, you got adequate ADH, which body is known to secrete, but once it gets exhausted in first few hours of stressful, that's the time perhaps you require ADH. So we had a huge discussion on this in our intensive care chapters also. What should be the choice? Evidence-based today, as on today, is still adrenaline. Previously it was dopamine, it's now out. It's all about adrenaline. Adults have moved on to noradrenaline, the first choice. So perhaps, who knows, either vasopressin or noradrenaline will be the first choice. But as on today, evidence is clearly in favor of adrenaline.
We use vasopressin quite often times for a low cardiac output state. I think it works in some percentage, and not in everyone. I think 50% of times I've seen the BP rise. If you have more than 48 hours, I think it's more kind of complication than the use. As Mohit sir has recently pointed out, vasopressin has taken this time to take a place, but it should be a time-tested drug, like adrenaline and noradrenaline. We use it quite since long years, so I think it is important to see whether it stand the test of time. Very important.
Okay. So if there is no question, then ask Dhananjay to give out of thanks.
Thank you, sir. As per the vision of our president, Dr. Manglesh, we have started this subspecialty CME once a month. Our third CME in a row of pediatric cardiology. And we have two wonderful speakers, Dr. Manglesh Nimbalkar, sir, and Dr. Bhushan Chavhan, sir. And our own, we can say our own pediatric cardiologists, both are very accessible anytime and very cooperative. We routinely get help from them in managing our patients. So thank you both of you for your wonderful presentation as well as answering all the queries in depth. Thank you both of you. I sincerely thank Dr. Ajay Koli sir and Dr. Vikas Bhandar for their wonderful moderation. Sincere thanks to our President Dr. Manglesh sir for his guidance. Thanks to Mohit sir, Sasan, Dr. Chitra Purkani madam, Dr. Sunil Sheth sir, and finally Dr. Vishal Rao sir, and all the delegates who have attended this session. Thank you very much.
Thank you, sir. Thank you.
Thank you.
Sir.
Thank you, sir. Thank you very much, sir.
Thank you very much.